So first of all, good morning, everyone. Thank you for joining us. We are about to start the webinar shortly at 9. So we appreciate your patience for waiting us. We are in process of setting up. Thank you very much.
Mas harus off ya?
I'm sorry, I'm just checking the live streaming.
Okay.
For a moment.
Okay. So the live streaming is already on ya, Mbak Saras?
Yes.
Okay.
Yes.
So for Amolat and also Dr. Zairisha, beside this online using Zoom platform, we also broadcast this through YouTube streaming. So other participant that cannot join this Zoom can join from the YouTube streaming. Yeah. Is there any college from Thailand join this, Amolat? You're still mute. Please unmute your voice. Yeah.
Okay. I'm sharing with the university that we
Okay.
have the connection.
Okay. Yeah. Hopefully the webinar can be joined by participants from Thailand and also from Malaysia and also from our country. Yeah.
I think there are some from Malaysia as well.
Okay.
Yes, I saw some students joining from Cyberjaya from the registration.
Okay, good.
And the number of participants almost 500.
Yeah. Actually, the registered participant is about 800 yesterday, Mbak Saras.
Yes.
Oh.
Yeah, but yeah, usually sometimes some cancel or some so, but I think this is good enough. We have about so far about almost 400. So
yes,
300.
400 plus. I think there are some also watching through the live streaming version.
Okay, yeah, from the live streaming also, yeah.
Yeah, because the information from the leaflet, the seminar is only for students.
Actually, not, but yeah, but we share also for the college, our pharmacist college, yeah, but no problem. I think our target is the students to see how is the clinical internship conducted in this hospital and also in Indonesia. Halo Mbak Vita.
Assalamualaikum. Apakah suara saya bisa
Iya, jelas ya.
Ya.
Kok pakai Mbak Anin namanya?
Oh, Mbak Anin? Oh iya.
Di rename aja.
Oh, kok bisa ya?
I don't know. Sometimes
Anin
happen.
dia. Oh, okay. So how can I rename? Which one?
Just click in the titik 3 itu Mbak, in your
more, and then Q&A chat.
No. On your photo on your Mbak Vita, gambar Mbak Vita, and di atas pojok ada titik 3.
Many titik?
Titik 3. Klik.
Wait. Bentar.
In our picture ya, in your picture. Terus di atas tuh ada mute and titik 3. Three dot and just click and there are several facility. Mute, stop video, chat, and rename.
Oh, sorry rename.
Udah already ya. Kok ujung-ujung berubah dewe?
Kok iso?
Entah,
Gitu.
something.
Di tempatku masih Mbak Anin.
Tapi ini udah muncul Bu Vita.
Oh gitu.
Iya.
Malah nggonanku dadi weruwer ki piye ki?
Ya, sometimes happen.
Oh gitu.
Okay, we can start ya.
Oh, oke.
Assalamualaikum warahmatullahi wabarakatuh. Hello everyone, this is Saras welcoming you to the International Collaborative Webinar on Clinical Pharmacy Internship. Today on Saturday, the 5th of September 2020. So this webinar is organized by the Master Program in Clinical Pharmacy in collaboration with Faculty of Pharmacy, University of Cyberjaya, and the Bumrungrad International Hospital. Today in our panelist room, we have Professor Agung Indro Nugroho, the Dean of Faculty of Pharmacy, Universitas Gadjah Mada, Professor Dr. Rena Triana Hertiani, the Vice Dean for Academics and Student Affairs, Dr. Satibi Ali Kusnadi, the Vice Dean for Human Resource Asset and Finance, and also we have the head of Master in Clinical Pharmacy program, Professor Zulis Ikawati, who is also the moderator for our webinar today, and also Dr. Vita Rahmawati, the Secretary of the Master in Clinical Pharmacy program. And joining us remotely from Malaysia, we have Dr. Said Rizah Ahmad Hisham from University of Cyberjaya. And joining us remotely from Thailand, we have Ms. Amonrad. Apparently she's going to be joining us later. And also our two students from the Master in Clinical Pharmacy program, we have Ms. Perdani Adnin and Ms. Anggraini Chitra, who will later share about their experiences in having the clinical internship in Malaysia and also in Thailand. And today's webinar will consist of the opening remarks from the Dean of Faculty of Pharmacy, and then the first session of the webinar, which will be led by Professor Zulis, and the second session, which will be led by Dr. Vita Rahmawati, and then the closing of the webinar, which is expected at 12. And right now, without further delay, I'd like to invite Professor Agung to give his opening remark.
Okay, thank you very much, Mbak Saras, for your time. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Salam sejahtera. Your Excellencies, honorable speakers, Board of Faculty, Professor Triana, Dr. Satibi, Professor Julis, lecturers, researchers, committee, and all participants. First of all, I would like to praise and thanks to God who has granted countless blessing, knowledge, and opportunity for us so that we can attend the two-day international collaborative webinar with the topic of clinical pharmacy internship in healthy and full of happiness. I do wish to keep healthy even though we are still facing a COVID pandemic. The event is organized by the Master Program of Clinical Pharmacy, Faculty of Pharmacy, Universitas Gadjah Mada. On behalf of the Faculty of Pharmacy, Universitas Gadjah Mada, we would like to thanks to our distinguished speakers, Mrs. Bumrungrad from Bumrungrad International Hospital. She will speak about clinical pharmacy services and preceptorship in Bumrungrad Hospital, Thailand, and also our distinguished speaker, Mrs. or Dr. Saisyah Ahmad Hisam from Faculty of Pharmacy, Cyberjaya University. She will speak about clinical pharmacy services in Malaysia, in Cyberjaya University College of Medicine, Medical Science, Malaysia. And also our distinguished speaker, Apotheker Anggraini Citra, Master of Clinical Pharmacist, fresh graduate of Master Program of Clinical Pharmacy and Pharmacist at UGM Academic Hospital. She will speak about learning experiences and example of case study from Thailand hospitals. And the last, our distinguished speaker, Apotheker Perdani Admin, Master of Clinical Pharmacy, fresh graduate of Master Program of Clinical Pharmacy. She will speak about learning experiences and example of case study from Indonesian hospitals. Thanks for your time, your sharing knowledge and experiences. It will be fruitful and useful for us to always develop and increase the academic and research quality in clinical pharmacy in Indonesia. Ladies and gentlemen, for your information, education in pharmacy is based on 5 pillars. There are pharmaceutical sciences, life sciences, pharmaceutical industry, clinical pharmacy, and social pharmacy. The clinical pharmacy is still developing in Indonesia in the last 2 decades. It is a challenge for us. Besides, Indonesian government have admitted the key role of clinical pharmacy in the hospital. It is very important for us. The government, Indonesian government, always support the development of clinical pharmacy, especially in hospitals, by releasing the regulation of the Ministry of Health of the Republic of Indonesia, number 72, 2016, concerning standard of pharmacy services in hospital. In this regulation of the Minister of Health, the standards of pharmacy services in the hospital are first, management of pharmaceutical preparation and medical devices, and the second one, clinical pharmacy service. It is a challenge and opportunity for us. Therefore, we are currently concerned about developing the clinical pharmacy. We have to prove the real clinical pharmacist. And finally, ladies and gentlemen, I do wish the event will be fruitful and useful for us. And by saying Basmalah Bismillahirrahmanirrahim, I open the online seminar today. Thank you very much. Bila taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera.
Thank you, Prof. Agung, for giving the opening remarks. As always, before we start the webinar session, we'd like to invite everyone in the panelist room to have a group photo session. So I'd like to kindly ask you to start your video for Prof. Agung and Dr. Ika. Okay, I think Prof. Agung is leaving, so everyone here seems to be ready. I will count 1, 2, 3, and on 3, I will capture the video. Okay. One moment. 1, 2, 3. Thank you very much. Okay, so before I give the floor to Professor Zulis Ikawati as the moderator for the first session, I'd like to share with you the ground rules, the regular ground rules. I think everyone has already been familiar with this. Okay, so first, please confirm your attendance by completing the following form. Please do notice that this form will be available until 12:30 only, and your microphone, for those of you joining via Zoom attendance room, your microphone will be automatically muted, and you will have the opportunity to engage with the panelists and each other via online chat room. Be respectful of other participants, and panelists keep your comment on topic and succinct. Submit your questions to the panelists in the Q&A window. You may mention the panelist's name to address your question. And we are sorry that for those of you joining us via the live streaming version of YouTube, we cannot really gather your questions. And do not post any requests for technical support in the chat room. Do not provide your feedback about the quality of the session. You will be given the opportunity to do this by completing a survey at the webinar's conclusion. And the link will be shown to your pop-up windows once you are leaving this webinar. And this webinar is recorded and is live streamed on the Kanal Pengetahuan Farmasi UGM YouTube channel. I think that's all the ground rules. Now I'd like to give the floor to Professor Zulis Ikawati. Time is yours, Prof. Zulis.
Okay, thank you very much, Mbak Saras, for the time. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. It is very honor for me to being the moderator in this session, and I would like to welcome our speakers in this session. Mrs. How to call you? Mrs. Amolat from Bumrungrad International Hospital, Bangkok, Thailand, and also Miss Chitra, Anggraini Chitra. Anggraini Chitra is the student of Magister of Clinical Pharmacy in Universitas Gadjah Mada. And in this session, Mr. Amolat will present about the clinical pharmacy services in Thailand and also how about the preceptorship doing in the Bumrungrad International Hospital. And Mak Chitra will present about the learning activity or learning experience in Bumrungrad Hospital, and also presents an example of the case study in Bumrungrad Hospital. And before I give the time for Amolat, I will little bit introduce Amolat. Miss Amolat received a Bachelor of Science in Pharmacy from the Faculty of Pharmaceutical Science, Prince of Songkhla University in 1994, and Master of Science in Clinical Pharmacy from Mahidol University in 1998. And now she worked in Bumrungrad International Hospital since 2003 as a clinical pharmacy specialist. And she is currently Department Manager of Clinical Pharmacy Service, Pharmacy Division in Bumrungrad International Hospital, Bangkok, Thailand. And you have about 30 minutes for give your presentation, and time is yours.
Okay. สวัสดีค่ะ Good morning, everyone. Greeting from Thailand. Thank you, Professor Suli, for nice introduction for me. Okay, let's start the first slide.
Mbak Saras, can you share?
Yeah.
Yep.
Yeah. Please slideshow. Today I would like to say my appreciation that UGM invites me to sharing in these sessions. In these sessions, I would like to present about two of part. One is the overview of clinical pharmacy service in Bumrungrad International, Bangkok, Thailand, and another one is the preceptorship and assessment from Bumrungrad. So next slide, please. Okay. This one is the overview of the patient journey. The clinical pharmacy service, if we focus on the patient journey, since patient admissions, we provide the pharmaceutical care by the ward pharmacists in the three of specialty. The first one is the critical care units. In Bumrungrad International Hospital, we have a ward pharmacist in critical care, 3 of the ICU unit, and 1 of the coronary care unit. And in the regular ward, we provide the pharmaceutical care in oncology ward and surgical ward. In daily, we have the daily round with the physicians and nurse, and also for multidisciplinary team such as the dietitian at the first 24 hours when patient admissions. The pharmacist will go to interview and obtain the information from the patients to make the medication reconciliations. And to resume the medication that is important if the patient needs to use a long stay with the hospital. The activities of the pharmaceutical care in each patient is to detect, resolve, and prevent the drug therapy problems. This is the practice that I think it is demonstrated a positive impact on the patient safety. So the clinical pharmacists, if they detect the drug therapy problem, they will discuss with the doctor and make the intervention to let the patients to receive the appropriate drug with their conditions. In the monitoring role, we implement the antimicrobial stewardship programs since 2016. We comply with the CDC core elements to categorize the antimicrobials in 3 categories. The first one is the pre-authorization antimicrobials. The second one is the conditional antimicrobials, and the last one is others. This program, the role of a clinical pharmacist is to review the indications of use, duration of the antimicrobial use, and the laboratory results to make the recommendation with their renal functions. And when the laboratory results have to de-escalation, change the antibiotics, and change from switch therapy from IV to PO also. For the TDM service, Therapeutic Drug Monitoring, we established since 2003. At the first, we focusing on the narrow therapeutic drugs, the vancomycin, amikacin, or gentamicin. And for now, Also with the voriconazole and low molecular weight heparin is in our service too. When patient ready to go home, the counseling in the narrow therapeutic drug such as the warfarin, because the warfarin have the many of drug interactions. So patient needs to know what the information to use of this drug, and also now expand to the DOAC or direct oral anticoagulants also. Also with the immunosuppressant drug and target therapy drug in the oncology patients. Not only in the narrow therapeutic drug, overall of the home medications, the ward pharmacists and clinical pharmacists will provide the counseling information to the patients. When patients in the ambulatory care or outpatients, we have the MTM clinic, medication therapy management clinic. Previously, we focused on the chronic disease as the diabetes, CKD, and stroke. For now, in the new technology, have to integrate the pharmacogenomics with the medication therapy management clinic. Many drugs of the medication have the pharmacogenomic testing. So when we give the patient pre-test counseling, and after the gene test result, we provide and advising, give the therapeutic support from the drug selection, drug adjustment, and drug monitoring, especially to preventing the serious drug event, especially in HLA genes for use the allopurinol and carbamazepine. Next slide, please. This one is the overall of the specialty in clinical pharmacy. If we focus on the critical care unit, the lead of the critical care unit is the pharmacist who receives the board certified of the critical care pharmacist and pharmacotherapy specialist. In the oncology pharmacy, will lead by the clinical pharmacist who receive the board certified of oncology pharmacist and nutrition support pharmacist. In MTM, integrated with pharmacogenomic also, lead by the board certified of pharmacotherapy specialist. In cardiology, Anticoagulant Clinic and PGX with the BCPS also. And everyone in critical care pharmacists and pharmacotherapy specialists help and support to provide a service of antimicrobial stewardship program and therapeutic drug monitoring. Next slide, please. This is the picture of the activity in Delhi. As I mentioned before, the clinical pharmacists will have the ward round with the physicians and multidisciplinary care, checking the drug, resolve the drug therapy problem. For now, it's easy to use the iPad to review the patient medication profile and walk to the patient room Next slide, please. As the Oncology Pharmacy, this one we provide in ambulatory care and acute care. At the first visit that patients would receive the chemotherapy, the clinical pharmacist will provide the counseling with the pre-medication before use the chemotherapy and management of the adverse drug event. When patient would like to, when they come to admission at the oncology ward, have the clinical pharmacy at ward to review the medication profile and discuss with the patient when have the ward round. Next slide, please. This is the preceptorship goal of Bumrungrad. We think that our pharmacists will be better able to, they will be the better in the side of professional, compassionate, and caring. In my opinion, I think if we cannot deny the role of preceptor, whatever position you may be the clinical pharmacist or in the management positions. When we take care our junior staff, we will need the skill of the preceptor. The senior staff will take care and give the support to the junior staff, and we work in the college, not only for the pharmacy student, but this will be in our mind and keep it day by day to continue. Okay, next slide, please. Next, please.
Next slide.
Okay, this one, as we have the UGM sent the student internship to Bumrungrad for about 3 years ago. In 2017, they have not owned their own criteria yet. So in Bumrungrad, we let the preceptor to adapt the career ladder adjustment criteria and the assessment from the Thailand University for the pharmacy student to have the brief assessment for Indonesian pharmacy student. This one, not only functional competency of the clinical application or pharmaceutical care, we also would like to the student develop themselves in the soft skills, the professionalism, the attitude, behavior, and responsibilities. As the punctuality of the in working, follow the dress code, attend our scheduled visit, and the can apply constructive criticism and respond appropriately feedback. By interact with the patient or the interdisciplinary team, in Bumrungrad, we are the tertiary care with the international patients. So the concern of the ethic issue and cultural is important also. Last but not least, it is a self-improvement and lifelong learning attitude for the pharmacy student. And in the package of we send the assessment to the UGM. We have the 3 parts. One of the UGM assessment. The second one is the Bumrungrad assessment form. And the last one is the certification to the student. Next slide. This is the example for the certificate of the internship.
Slide.
Yeah. We send by email at the soft file to UGM by Suli and Fita first, and send the hard copy by airmail to Indonesia again. Okay. Next, please. I think that's all my presentation. If you have any question.
Okay. Okay, thank you very much, Amolat, for your presentation. Yeah. After the Chitra presentation, we will have a Q&A discussion, Q&A session. Yeah, so please wait. And yeah, for information for all participants, Bumrungrad International Hospital is, I think, one of the best hospital in Asia, I think. Yeah, and we already have a collaboration and send our students for clinical attachment since 2016 to now. But unfortunately, due to the pandemic this year, so we cannot send our students. So that's why we have this seminar for still giving to share the experience and also to introduce how about the clinical pharmacy and also the preceptorship in Thailand. Hopefully next year or maybe the next year we still can have opportunity to send again our students. And one of the student already do the clinical internship in Bumrungrad is Mbak Chitra. She's now just graduate, yeah, Mbak Chitra, but not yet the graduation ceremony, but already get a judicium, and she did the clinical internship last year, yeah, Mbak Chitra, last year in Bumrungrad in the field of cardiology. Yeah. Okay, Mbak Chitra, please share your experience about 30 minutes, and then we will have a Q&A session. Please, Mbak Chitra.
Okay. Okay, is everybody can see my slide and also my voice?
Yes.
Yeah, okay. Okay, good morning, everybody. Thank you for the opportunity that has been given to me. And today, I will give a presentation with the topic Learning Experience and Example Case from the Thailand Hospital. Yeah. Maybe at the first, I want to introduce myself. My name is Chitra, and I am a student of a master program at Universitas Gadjah Mada. Why did I choose UGM as a school place? Because beside the clinical pharmacy master program has been accredited A, the clinical pharmacy master program also offers opportunities to study an internship program abroad. And the students are given the option to determine the clinical rotation, and I choose the cardiology as one of my options. And for the cardiologists, the clinical pharmacy master program offers internship programs in and outside the country. And for the outside country is Thailand. Then I choose Thailand. Yeah. And the question is, why Thailand? Well, actually, I have heard that the development of the pharmaceutical world there is very advanced. And what caught my attention was the warfarin clinic that was developed there, like Mrs. Amonlat mentioned previously. So this makes me very excited to be able to learn this more deeply. And here we are. Yeah. I had the opportunity to undergo my internship program for a month at Bumrungrad International Hospital in Bangkok. And as we can see in this picture, that Bumrungrad is a very big hospital, and the Bumrungrad Hospital is a private international hospital that has been accredited by JCI, or Joint Commission International. And on the slide, it shows our picture with of me and my partner with Prof. Zulis, who accompany us at the first day, and also our clinical preceptor. Okay, let's see my training program in the Bumrungrad. In the first week, our clinical rotation is in cardiology ward or 10C ward, and for the second week in Anticoagulant Clinic and Drug Information Services, third week in Medication Therapy Management Clinic and TDM Clinic, and then at the fourth week, TDM and CCU. Okay, in this slide, I would like to share with you about about our activity in cardiology ward. So the interesting thing in Bumrungrad International Hospital is for the hospital international system, for hospital information system, they use the track care system. Maybe still use it until now. I'm sorry, I don't know the updated. Maybe Mrs. Amolat can correct me if I'm wrong. So the track, yeah. So the track care system is a good system that provide the clinical pharmacy to do the patient assessment. And now I just want to share you one of my case in the cardiology ward, because in my first week we do some assessment to the patient, and then we do the case presentation. Yeah, as you can see, this is me and my preceptor doing the presentation. So the case is Mr. X, 60 years old, referred to hospital for further treatment. The patient developed dyspnea, fever worsened, and neck pain. Workup from hemoculture shows strepsils septicemia. For the MRI neck, it is shown that the patient had a cervitis at C5, C6, and CE show thickening of all leaflet and the aortic value with moderate AR, or aortic regurgitation. Was treated with antibiotic in another local hospital in Thailand, and he was diagnosed with IE with strepsils. IE is in infective endocarditis with severe AR. So this patient has many medical problems, but I want to emphasize with the one medical problem. Medical problem that is AF, or atrial fibrillation. Okay. When the patient first admitted to the hospital, the clinical pharmacist in Bumrungrad International Hospital do the medication reconciliation, as well as we do in our hospital in Indonesia. So the medical reconciliation is important, is the important step, because we can know what is the historical of the patient, his medication history of the patient. So in this patient, the medication reconciliation shows that the patient is using enalapril 5 milligrams, a half tablet, and frequency that he used in home is take orally 1 time daily in the morning after meal. And then this medication is discontinued while the patient hospitalized. And then Concord, a half tablet, take orally 1 time daily in the morning after meal, and it's also discontinued. The interesting thing of the track system is there is a medication summary that you can see in my slide. So the medication summary will summarize all the medication that the patient using in when hospitalized. And when the patient is refused to the medication or the medication is hold because the some reason, uh, there will a sign like this R. It means reviews. So the clinical pharmacist can monitoring and know if the patient still consume the medication. Okay, and from the SOAP assessment, we can see that from the objective data, subjective data, the patient was diagnosed as ischemic heart disease 20 years ago, but no significant treatment. And then the CIF complaint is fever worsened. At 7 September, the pharmacist notified that the patient had a tachycardia but no chest pain. But at 19 September, the patient feels well. The patient developed EF with fast ventricular response this morning and entirely asymptomatic. So for the objective data we are collect is that related for the subjective, right? So the subjective is the patient notify the tachycardia, and the objective, of course, the heart rate. It shows that the heart rate of the patient is 130 beat per minute. And the EKGs show the AF rate 130, no new ischemic specific STT change. At 19 September, the heart rate become 128 beat per minute, and the patient has already gave a cordaron 100 milligrams IV stat. It means when the patient is knowing have a tachycardia, so the doctor give the cordaron once for just one IV push. And then the patient also take Pradaxa. Pradaxa is anticoagulant. And then the cordaron is still continue until September 21. So the objective data we get is cardiac cath with coronary angiogram showed the severe aortic insufficiency near normal coronary arteries but good LV, and the patient is planning to be doing some AVR or out of replacement. Yeah, this is the assessment for the patient. So the patient when the patient come with the tachycardia and AF, so the therapy and dose and the frequency is appropriate for cordaron. Okay, because after the cordaron is taken by the patient, so the heart rate is become 90 beats per minute. But the chat-fast score, the pharmacist will calculate the chat-fast score that and the score shows 3. It means the patient at a moderate high risk and should otherwise be an anticoagulant candidate. So the therapy will be warfarin. Yeah, as we can see in this case, the warfarin is anticoagulant and needs more monitoring for ENR. So the pharmacist do the ENR monitoring for the first anticoagulant therapy. Yeah. As you can see this, the pharmacists do the monitoring every single day. In when the doctor give first dose is 5 milligrams of warfarin, then the ENR will be checked the level in the blood. Okay, and we can see that the ENR level for this patient is still in a safe level, but there is a drug interaction. So previously, Ms. Amonlat said that the clinical pharmacist or the ward pharmacist should prevent the GRP or drug-related problem. And the interaction between warfarin and amiodarone is potential drug interaction. The mechanism is amiodarone may increase the pharmacologic effect of warfarin by inhibiting CYP40 uh, 450 450 to C9 hepatic metabolism of heparin, and it will be resulting of hypoproteinemia and bleeding. So what is the plan then? The plan is the pharmacist is recommend to use warfarin 3 milligrams, one tablet, one time daily in the evening after meal. And the patient should be educated by warfarin education and recommend that the target ENR at 2.5, ranging from the 2 until 3. And the counseling discharge for the warfarin, the pharmacist will educate the patient for good oral health maintenance, preventive dentistry, and advice of skin hygiene. And what is the management of drug interaction? So the pharmacist and also the patient will monitoring ENR level, and if ENR level is raising above the range, so the pharmacist will recommend to use reducing dose for anticoagulant 30 until 50%. And advise to the patient to notify the physician if they experience any signs of excessive anticoagulant such as prolonged bleeding, brushing, vomiting, change in stool, and etc. So the warfarin education, such as indication, doses, how to take warfarin, how to monitor UNR level and the target UNR range, signs of major bleeding and sign of thromboembolism event, drug and food, which have interaction with warfarin and activities that may cause serious injuries. Okay, the next rotation is Anticoagulant Clinic. So related to the case, the interesting thing in this clinic is the pharmacists provide the brochure or leaflet that eye-catchy and it's very interesting to the patient who can read this, and they will educate the patient about what is the warfarin and how warfarin affect the blood, and then what do they need about the warfarin, and all the education activity or all the assessment patient is documented in track care system, so every pharmacist can monitoring the patient. And the interesting rotation clinic, another interesting clinic is MTM or Medication Therapeutic Management Clinic. Actually, this is something new for me because maybe in Indonesia, uh, we just know that, okay, there is a MTM, but I don't know how to do the MTM. So MTM, when I learn about the MTM activity, so it helps outpatient to resolve drug-related problems, DRPs. So it will help in the outpatient services, and the patient will be the pharmacist will help the patient to resolve drug-related problems. Yeah. So what the pharmacists do is the first is medication reconciliation, and also the pharmacists have an access to know what is the medication history, what is the over-the-counter medication that the patient use, what is the herbs or food that the pharmacist consume every day, and even with who the patient is live with. So the pharmacist very detailed to use to make a assessment for the patient. So I think the MTM aims is to help patients to get better outcome by understanding the disease and particularly the medication that used to manage the disease. Patient will be educated and consulted to improve the understanding of their medication, improve adherence, and detect adverse drug reaction and improper medication use. And one of my activity when I follow my preceptor is we are follow the geriatric patient with polypharmacies and many doctors to take care of her. So yeah, we do some medication reconciliation and we do some counseling and we ask her what is your difficulties to manage this medication, and the pharmacist will help her to resolve her problems. Okay, and now maybe it's some pharmacists in Indonesia. It's wondering what is the therapeutic drug monitoring, right? Okay, for the TDM practice, the TDM is intended to monitoring drug doses in the bloodstream, especially for amikacin, gentamicin, and vancomycin. And then in this clinical rotation, we provide the doses recommendation to the doctor. Maybe in our mind, maybe in my mind, therapeutic drug monitoring is expensive and then needs a special tools to assess it. But one thing that we forget, that we have the knowledge of the pharmacokinetics, that maybe not we it's not usual, not always doing, we not often to do this pharmacokinetic calculation to estimate the C-peak or C-trough of the drugs. So this is what I'm learned. Yeah, this is the TDM worksheet, and I will share you one of the drug. Just for example, this is for amikacin. So maybe all of you is know about this equal or this formula. Okay, maybe we just review this formula. So this formula is to know about to estimate, to calculate the estimation of C peak and C trough, and also the K elimination. So I have a case, yeah, as an example case for the TDM calculate. So there is a 62 years old male, weight 56.4 kilograms, height 162 centimeters, with the serum creatinine 0.5 milligram per deciliter, was planned to receive amikacin 15 milligrams every 12 hours and drip in 1 hour. So can you guys calculate the population parameters, peak and true level at steady state using that formula? I will give the quick answer because I already calculated before. And all we do is we have to know what is the clearance creatinine of this patient. So if we know the clearance creatinine, and then we can do the next step of the calculation. So we can know what is the Ka, we know the half-life of the amikacin, also the volume of distribution of the patient. With that formula, we know that the C-peak or C-max of this patient is 37.31 milligram per liter, and C-trough or C-min is 5.625 milligrams per liter. So why this is so important? Because if we know the range about the C-peak or the C-trough, we know that the concentration amikacin in the bloodstream is safe for the patient. We cannot give the dose of amikacin if the C-peak is above the range, and we cannot give the amikacin if the C-trough is above the range. The range of the amikacin for the C-peak is about 20 until 40 milligram per liter, and for the C-peak is 5 until 10 milligram per liter. Because when the level of the in the bloodstream is above the range, the patient will be side effect like ototoxic, because the amikacin have the narrow therapeutic index. Yeah, so that's why it is so important for us, and that's why we have to know the pharmacokinetic population calculation using that formula. Okay, this is my last slide. So this is my preceptors, our preceptors, that I many thanks to you because I can learn. Yes, many things I can learn from Bumrungrad. This is, can I mention one by one? This is Pipum, thank you, and this is Pihua. From Pihua, I learned about MCM Clinic, and from Pijo, I learned CCU ward, so the activity in CCU ward. And this is PTAP, yeah, my preceptor. Thank you for your kindness, your welcoming for us, because you are very helpful and very kind, accompany us, and always answer all my our question. And also for Ziri, okay, Ziri, maybe she's joined this webinar, I don't know, but if she joined, I would like to thank you very much, because Ziri is my main preceptor.
Yeah.
Yeah, this is our friends in Bumrungrad. So in Bumrungrad, we met many students, pharmacy students especially, yeah, from Chiang Mai University, and oh sorry, I forget the the university, but very humble and very friendly. So in a we can take break together, have a lunch together, and yeah, this is very fun. Okay, and my last slide is take-home message. A clinical pharmacist plays an important role in ensuring the safety of treatment regimens. Pharmacists regularly update their knowledge and skills to keep up with current trends in issues related to drug therapy management. Okay, thank you for the time, and I will give my time to Professor Julius.
Okay, thank you, Mbak Chitra, for your nice presentation. I'm sure that it was very nice experience and also very beneficial for you, yeah.
Yes,
and
of
also,
course.
yeah, thanks for sharing with us. And yeah, for all participants, maybe someday you can also join such experience, yeah, in Thailand, and please join us in the Master of Clinical Pharmacy in UGM first. Yeah. Okay, now we come to the Q&A session. I saw in the Q&A window, there are already several questions. First, the first question is for Miss Molat.
Yes.
Yeah. From Agil Bradley. He or she, he asked, I just wondering how pharmacist recommendation acceptance by physician or specialist in Bumrungrad Hospital. Yeah, because usually the pharmacist after review the DRP and then give recommendation. So how is the acceptance of the recommendation by the physician?
Okay, at the average of overall of clinical pharmacy service is the 95%.
95.
Yeah, overall average in the therapeutic drug monitoring is 99%.
Almost all,
Acceptance.
yeah, almost all
Yeah.
recommendation of pharmacists are accepted by the physician, yeah.
Yes. Yes.
Okay, yeah, very interesting. Yeah. How about the other? Beside the TDM?
Other TDM 99%. I think the area of improvement or maybe the MTM clinic is the less, about 90%, I think,
90%,
because the patient take the patient have the polypharmacy. They have many drugs or medicine, and some patients not is not not is the only with the Bumrungrad only, but they care with the other hospital also. So in the medication reconciliation profile have the many drugs. So we cannot intervene or give recommendation in the other of the medicine of this.
Yeah, of course. Yeah. So, but I think it's very interesting, with the 90% acceptance of the physician for our recommendation is very high, I think. Yeah, I hope in Indonesia also, I think maybe because the physician in Thailand already know about the clinical pharmacy service,
Yes.
So they collaborate very well, right?
Yes.
Collaboration is very well and in the team, So this is very interesting, but we still in Indonesia, we still improve or still try to more acceptance of our recommendation. Okay, then the next question is come from Palevi Rufliana Sari. She asks about what are the terms of use of meropenem in Bumrungrad Hospital?
Meropenem.
Meropenem.
We categorize in the second category of the conditional antimicrobial. So at the ASP antimicrobial stewardship program, the meropenem will review the indications, and after the laboratory of culture result, we will consult the physician to de-escalate the treatment or change to the narrow antimicrobial one. Depends on the patient's indication also.
Okay, okay, thank you. So how about Palevi? I hope this answer is can accept it, can be accepted. Okay, next question is for Mbak Citra. Mbak Citra, Apotheker Julie asking about how to make a swab, SOAP, because she asked the patient. Let's say we put the feeling of patient in subject swab, not affecting as I see in the first case. What do you think? So I mean, what should be put in the subjective and what in the objective? Because maybe she thinks a bit different with okay.
Okay, thank you for the question. So, for the subjective, yes, we have to write the chief complaint of the patient. So in my slide, I writing down the chief complaint of the patient is fever worsened, and maybe for the slide it is I just to try to describe what is the patient felt. So in the reality, the patient is talked to us that he felt fever, and then he felt what is that, tachycardia, right? And when he complained that signs, and the objective data will be there is a what is assessment with AKG that prove that the patient is had a tachycardia. So the subjective is for the chief complaint, what the patient feel about their body, what is the patient feels about their health, the condition of their body. That's like this.
Okay, so the subjective data is about what patient feel, what patient feel and the chief complaint of the patient, and the information about the drug or the medication will be put in the objective data,
The objective
right?
data, yes.
With the laboratory test, for example.
Yeah, but related for the subjective.
Yep. And Julie, Apotheker Julie still continue with her question. Did you visit the patient directly in the ward, or
Yes.
just take the data from the EHR?
Okay. Sometimes we let to visit the patient because not all the patient can visit because this is a private hospital. So we have to ask the patient first. Do you like to visit by the students? So for the patient, I have opportunity to visit him once.
Okay, so you have opportunity to visit one patient there. Yeah.
More than one actually,
More
but
than,
for
yeah.
this patient is once.
Okay.
Yeah.
So from where? Thailand, Thai patient or other? Because this is international hospital, right?
Yes, if I'm not mistaken, it's from Myanmar or something.
Okay.
Yes,
Yeah.
Myanmar.
Because,
Yeah.
yeah. And speak English, yeah.
International. Speak English.
Yeah. So the requirement to do such clinical attachment in Bumrungrad should be speaking English, yeah, fluently lah. So because there is international hospital, so
Yes.
the patient also come from many countries, yeah, in the world, yeah. Okay. And did clinical pharmacy there always accompany student in
Of
to
course.
the work? Yeah.
Of course.
So
Yeah.
you visit the patient with
with my
your
preceptor.
preceptor, yeah, the
Yes.
preceptor.
They have
Okay.
to supervise the student.
Yeah. So you communicate directly with the patient?
Yeah. If the preceptor let us to assess the patient, then we will communicate. We will discuss with the patient too.
Yeah. Of course, we have to ask permission from first, yeah, from the patient, yeah.
Yeah. There's an
Yeah.
informed
Yeah.
consent. Yeah.
Informed consent whether he or she accepted or not to be
Yeah.
visited by the students, yeah.
Yes.
Okay.
Absolutely.
Yeah. Okay. And thank you, Machitra. This is other question from Amolat. Yeah. Ms. Amolat, how did you build up the Anticoagulant Clinic in MTM clinic in your hospital? Maybe you can share your experience. How to firstly start the Anticoagulant Clinic and also MTM clinic.
Okay, thank you for questions. I think in the for MTM since 2009 and anticoagulant is 2008. So with the JCI accreditation, they need pharmacists or the patient who take the narrow therapeutic drug to have the knowledge and adherence and prevention the adverse effect also. So this will we have to transform and adapt and implementation with the narrow therapeutic drug first. And also for MTM clinic, at the previously we have the accredit with the CCPC program. Is the for chronic disease program of the JCI. So we have the multidisciplinary team and pharmacists be one of the multidisciplinary team. One patient come to enroll to the program, there will be the physician, the clinical coordinator nurse, and the clinical pharmacist. So when the hospital have the quality program to provide the patient, the implementation of the clinical pharmacy service is easier and have more support from the management board of the hospital. Yeah.
So how many pharmacists involved in this anticoagulant clinic and also MTM clinic?
For MTM, now we integrated with pharmacogenomics. So we have in Delhi, we working for two clinical pharmacists.
Two clinical pharmacists?
Delhi, yeah.
Okay.
And anticoagulant is one clinical pharmacist. But in our team, our clinical pharmacy staff, we encourage them to can play the multitasking role. So they have a group of the clinical pharmacy clinical pharmacists who can provide the coagulation counseling about, I think, about 4-5 clinical pharmacists, and MTM, I think, will be the same. Yeah.
Okay, okay, yeah. Yeah, it should be collaborated with other health professional, yeah?
Yes.
Yeah, yeah, okay. Okay, thank you, Miss Amolat. And one more question for Miss Amolat. How about the COVID-19 management in your hospital? It is very interesting question. Nowadays, COVID-19 management.
COVID-19
Yeah. And how about the role of pharmacists in this management of the COVID-19?
Okay. In hospital, target or goal, every employee should not be infected with the COVID-19. Also, we have the criteria and prevention when patient come or the one who come in the hospital. In the role of pharmacist now that I have not mentioned before is the telemedicine.
Okay.
As the MTM clinic and Anticoagulant Clinic in the COVID-19 period, patient cannot come to the hospital, or they afraid to coming.
Yes.
So we provide the telemedicine to talk, to counseling with the patient. For warfarin, patient can take the kit to test their INR and call us, and we can tele by iPad to counseling with the patients. And MTM also, if patient cannot come or the new case would like to consult, we provide the telemedicine to the patients.
Okay, very interesting. Yeah, with the telemedicine, usually for the MTM clinic and anticoagulant clinic, because the patient cannot visit the hospital. Yeah.
Yes.
But how about the COVID patient itself? How about the COVID patient?
The COVID patient, we have the ICU only, that the negative pressure room is a separate area of ICU dedicated for COVID-19.
For COVID-19.
Yes, and one of floor is the top floor of the 12th floor of inpatient ward. We got also dedicated for COVID-19 patients. So the lift cannot reach at the 12th floor. Only the person or the healthcare provider with responsibility, with their responsibility, only can reach this ward.
Okay, yeah. Spirited from other facility. Yeah.
Yes.
And how about the role of the pharmacist for this kind of patient?
For this kind of patient, we do everything, but not contact.
Not contact.
Yeah. For the medication reconciliation, if the patient take their own medication, the nurse will review first. If they cannot fact find we use the telemedicine to the patient at the patient room. We can talk the patient by the iPad also.
I see. Yeah. So no contact with no direct contact with the patient.
No need to direct contact.
No need. Because we only provide the medication, and also to do the reconciliation we can do by the telemedicine. Using iPad.
Yes.
Okay.
Yes.
Okay. Thank you for this answer. And the next question addressed to Mbak Citra. Mbak Citra, this is from the Apotheker Sri Rezeki Amalia from Pinreng, South Sulawesi. Can you compare the clinical pharmacy in Indonesia in Thailand? What is maybe the main difference? Yeah, because the difference may be many, but what is the main difference?
Well, it's very difficult to answer because I think actually the pharmacists in Indonesia are qualified and had all the competencies to do the pharmaceutical care services in the hospital and also in the community. So maybe the difference is uh, the, the pharmacist in Thailand is involving directly to the patient, right? Maybe in Indonesia, sometimes the hospital just hired not so many pharmacists. So the pharmacist maybe is multitasking pharmacist in Indonesia, right? So yeah,
More
yeah,
powerful, yeah.
yeah. So multitasking pharmacist. So the pharmacist doing some managerial stuff and also the clinical stuff. But in Thailand, they will absolutely separate it. For the clinical pharmacist, they only give the services to the patient, and for the managerial is it's divided to with two divided into two department, right? Like that. But for the competencies, I think Indonesian pharmacist has the competencies
The
and
same competence.
yeah, and can do what the pharmacists in Thailand do. Yeah, because maybe just what is it called in Indonesia, we know istilah lebih pede saja.
More confident.
Yeah, feel more confident to doing your clinical pharmacy services. Just
Yeah, but I heard from Amolat also they are certified, yeah.
oh
All of
yeah.
clinical pharmacy already have the board certification, right, Amolat?
Yes,
Yeah.
yes.
So all clinical pharmacy, beside have the clinical pharmacy graduation, and they also certified, have the board certification in specific field. Yeah, that's right.
Yeah. If the they will growing in the clinical pharmacist or senior clinical pharmacist specialist, they have to apply with the board certified by
From where the board certification
this
from?
this is from ACCP, American
I see. Yeah.
College of Clinical Pharmacy. So
Is it difficult to get this?
difficult, I think. Difficult for because it is a many topics to take the exam, but not. I think
Not impossible, yeah.
Not impossible, yeah.
Not impossible, but yeah, I think maybe not easy also.
Not easy.
I think maybe I would like to encourage more clinical pharmacists in Indonesia to also apply the board certification, yeah.
You can see at the AHHP or ACCP or candidate guide. They will launch the examination for 2 seasons yearly. At the spring around we'll take the exam about in the end of April and 2 weeks, the last week of April and the first week of May. And for fall season, the last week of September and the first week of October. For now, it's the COVID-19 period. The spring that will postpone from April to only in, I think, in the August last month.
Okay, yeah.
But can take by online.
Yes, of course, yeah.
Official site.
Official site. Yeah.
Official site of of each country.
Okay, yeah. I think we encourage all our college in Indonesia to try to apply this certification. Yeah.
Yeah.
The next question still for Amorat. There are two questions, but the almost similar question about TDM, therapeutic
Yes.
drug monitoring. Actually, Mbak Citra already mentioned about the TDM in her presentation, but this question addressed to Ms. Amolat.
Yes.
Is there almost all patient covered with TDM or only on ward, and how to do it? About the therapeutic drug monitoring, the TDM. Is there any characteristic patient who will get the TDM service?
Oh,
Yeah.
okay. We focusing on the medications. The patient who receive the vancomycin, amikacin, all patient who receive this, in the morning we print the daily report, which one receive. And for the new one, we calculated the population pharmacokinetics parameter and recommendation for the in the first dose, depending on the renal function or creatinine clearance as the formula of the Chitra share. And then when the therapeutic level be in the therapeutic is the steady state, we recommend the physicians for obtain the blood level and calculated the appropriate dose for each patient. For the voriconazole and low molecular weight heparin is case by case by request. Doctor, if doctor think that it's not the routine, it's not routine to take the blood level.
Okay, so there are two kind. One by request, and
Yes.
one is automatically assay. Yeah. For
Yes.
the automatic assay for the TDM is for vancomycin and amikacin.
Amikacin.
Only two.
Yes.
Only two drugs.
Only two.
Okay.
Yeah.
This is
That
a routine.
pharmacy have the involved.
Yeah, pharmacy involved, and also the result of
Others is a
TDM.
case by case.
Yeah.
There's anti-epileptic drug,
Okay.
or vancomycin, voriconazole, low molecular weight
Yeah.
heparin.
This is a case by case. Yeah. Upon the
Yeah.
request from
Yes.
patient. Okay. Yeah. Okay. So there are not not all drugs actually.
Not
Yeah.
all the.
So only the drug with the neurotherapeutic index, and especially in vancomycin and amikacin, yeah, in Bumrungrad, yeah, and all of
Yes.
the recommendation from the pharmacist is accepted by the physician, yeah, for the
Yes, sir.
TDM. Yeah,
Yes.
yeah, okay. And the last question, because we have a limited time, the last question still for Amolat.
Yes.
Is there any committee of controlling antibiotic resistance in Bumrungrad?
In Bumrungrad, we have the infection control committee, which is a big committee. So we have the subcommittee of the antimicrobial stewardship subcommittee. The infection control committee have the laboratory technicians, have the informatics officer also, because in the antibiogram which we launch in the intranet, everyone can access the antibiogram and see which drug have the percent of resistance and can choose the appropriate antimicrobial. So in the subcommittee of the antimicrobial stewardship program have established about 3 years ago for focusing on the antimicrobial use. Okay.
Yeah. How about the way? I mean the procedure in the
procedure of the subcommittee.
Yeah.
We, as I mentioned before, that we comply with CDC core element in 3 categories, and we collect the data and present to the subcommittee in quarterly. if we, but in monthly we send by email, what of the percent physician acceptance, percent of the de-escalation, the use of antimicrobial.
It's done by pharmacists.
Yes,
yes.
by pharmacists is in the daily activity with the detected the DRP, drug therapy problem also.
Yeah. Okay. Thank you very much. So yeah, this is already established for this committee for controlling antibiotic resistance in Bumrungrad Hospital. And still one. Is there any one clinical pharmacist cover how many patients usually in the
depend on what. For if, as I mentioned that at critical care we have the 3 of critical ICU, but each ICU not the same quantity or same base. It's around 15 to 19 base in critical care, but in the TDM have for about 20 for daily, 20 patients for daily. But if we have to workload, we can let the colleague to share. But because some area have not much patients. It depends time by time.
Yeah. And already specialized, the clinical pharmacies already specialized for a special field, like oncology and other.
Yes, I think one of the success factor of the percent physician acceptance is high of more than 95% is we have the specialist in each clinical service. So when give the recommendation, the physician that accept which of the clinical pharmacy recommend.
Because they trust the clinical pharmacy.
Yes.
It's more especially for specialists, clinical pharmacy.
Yes.
Okay, I think this is all of the Q&A session because we have limited time and already 30 minutes for the question. But I'm very happy because many questions from the participants already answered by the Bu Amrolat and also Mbak Citra. And I hope this can give more insight and experience and for our college in Indonesia and also in other country, in Thailand and also in Malaysia. For information, this webinar is joined by our pharmacy college in Thailand and also in Malaysia, beside from Indonesia. Okay, I will finish this session, and after this session, we still have another session with Bu Vita, for the moderator. Okay, again, thank you very much for Ms. Amolat and Ms. Citra for a nice discussion this session. Thank you very much. Assalamualaikum. Okay, so please Mbak Vita for the next session.
Thank you very much, Prof. Julis, for the time. Now we come to the second session. There will be 2 presenters. First is Dr. Sairsiah Ahmad Hisham from University of Cyberjaya that will talk about the clinical pharmacy service in Malaysia and preceptorship in Cyberjaya University. And the second presenter will be Ms. Perdani Adnin Mainsyah. First of all, let me read about the curriculum vitae of Dr. Sairsiah Hisham. She is currently as the Deputy Dean of the Academic Affairs at Faculty of Pharmacy, University of Cyberjaya. She received her Bachelor of Pharmacy from UCL, School of Pharmacy in London, and then followed by postgraduate in clinical pharmacy from Queen's University, Belfast, Ireland, and take the PhD in the University of Cyberjaya. From her career, she started work at the Royal Hampshire Hospital in UK in 1999. Then she come back in Malaysia in 2003, and she worked at the UKM Medical Center on clinical pharmacist department. And 2009, she joined the Cyberjaya University, and she her interest in the pharmacotherapy, cardiology, and critical care. I think this is a little bit same with me, that we have same interest in the cardiology, doctor. Okay, for the next presentation, we have 30 minutes to present the presentation for Dr. Sairisa Ahmad. So Dr. Sairisa Ahmad, welcome to the stage.
Okay, Assalamualaikum and good morning, everyone. Firstly, I would like to thank Prof. Agung, Prof. Zulis, Dr. Fita, and UGM in general for inviting me to this webinar, to talk in this webinar. The title given to me is quite broad, so I will do very quickly on each areas. I will cover 3 areas. One is clinical pharmacy services in Malaysia. Second is clinical preceptorship practices in our University of Cyberjaya. And I think when we met quickly yesterday, we talked about the difficulties of conducting clinical clerkship or clinical internship during the COVID-19. So maybe we can just share a little bit on what we did during the COVID-19 movement control order, MCO, how we convert clinical clerkship to online clinical clerkship. Okay, everybody can hear me clearly, right?
Yes.
Yes, okay, thank you. Right, so a very brief description on the evolution of clinical pharmacy services in Malaysia. So in the 1990s and before that, there's no clinical pharmacy services in Malaysia, where clinical hospital pharmacists are mainly involved in just dispensing as the main activities. Pharmacists do go to the ward, but at interval, mainly only to conduct ward checks. Then in the late 90s and early 2000, ward pharmacists started to follow ward rounds, conduct interventions, but mostly the interventions are corrective, meaning that the prescribing errors or medication errors have occurred, then only we correct them when we see them. And we also do bedside counseling, TDM, therapeutic drug monitoring, and TPN, the parenteral nutrition. However, during this period, ward pharmacists are either not full-time, maybe they are also like inpatient pharmacists, for example, or they only go to the ward when we get referral. Say, for example, the ward call us up to counsel patient when patients just started on insulin or inhalers or warfarin, or for TPN and TDM. From 2004 onwards, is a very exciting period, because this is when our clinical pharmacy services in Malaysia aggressively expanded. With the support from Ministry of Health, the Pharmacy Division of Ministry of Health, we sort of venture into a lot of areas. For example, myself in coronary care, a few other colleagues in ICU, in pediatric, the areas where nobody saw pharmacists before. So from 2004 onwards, or in some settings maybe slightly earlier, we go into the specialized areas. So we become full-time clinical pharmacists instead of just ward pharmacists on referral. And at the same time, we also expanded and established medication therapy adherent clinics. In fact, this is similar to the MTM in Thailand. And we are also involved in quite many other things. We started medication reconciliation. Previously, it wasn't a properly established service. And we also get involved in many committees, for example, infectious control and AMS, the antimicrobial stewardship later on. So what's happening now? Alhamdulillah, now clinical pharmacists are well recognized within the hospital setting. We are always part of the multidisciplinary teams. This picture here is actually a picture of my colleague in Hospital Serdang, pharmacist of Hospital Serdang. This is the DM MTAC team who work hand in hand with the medical doctors and the nurses to organize the World Diabetes Day. So these multidisciplinary approaches may not be that common maybe 20 years ago. But now clinical pharmacist is well accepted within a multidisciplinary teams. With this establishment of clinical pharmacy services in Malaysia, the issue of what's the direction, some of the clinical pharmacists, if they've been in the service maybe from the late 90s or early 2000, like myself, you'll be clinical pharmacist maybe for 10 years or more now. So you will see that like our medical counterpart from maybe HO, house officer, medical officer, they are all now specialists. But clinical pharmacist is still clinical pharmacist. So we don't have clear pathway. Myself, for example, after 10 years in service, I jumped into academia for new challenges. But there are many clinical pharmacists who enjoy doing the practice, but would like to have more challenges. So that's where the credentialing and subject matter experts, SME, come in, which I will talk more later. Right, this is just a snapshot of clinical pharmacy services in Malaysia. It's the same as in Thailand or many other countries in the world. Obviously, the clinical pharmacy services has expanded from just walk round and counseling and TDM to many more, like for example, medication reconciliation. In Malaysia, we have a very well-established protocol on how to do medication reconciliation. For example, all pharmacists or clinical pharmacists of the ward should actually conduct the medication reconciliation within 24 hours of patient admission to the ward. And there is specific form, we call it CP1, to be used when we do medication reconciliation. Some pharmacists go into antimicrobial stewardship, AMS, right? And in recent years, clinical pharmacists are also expected to do clinical audits and research. This is very important actually, because this is where we can show the evidence of our services. As we mentioned earlier, clinical pharmacists also conducted MTAC, also conducted a number of continuous education sessions for other healthcare profession, because when we do ward rounds, we do corrective interventions. But in some hospitals, especially teaching hospitals, where the medical doctors change quite frequently, after a few months, you see the same errors again. So this is where preventative interventions is required. Hence, we proactively conduct education session to highlight on what are the medical errors, medication errors or prescribing errors that commonly occur and how to avoid them. Similarly, pharmacists also actively involved in establishing local guidelines, say for example antibiotic guidelines or the hospital antibiotic guidelines and things like that. And as you can see, these days, more and more clinical pharmacists are also part of task forces to establish national guidelines. If you look in all the Malaysian clinical practice guidelines, you see a lot more of pharmacist name. Some of them or most of them are clinical pharmacists as compared to maybe 10 years ago. On top of that, some pharmacists also ventured into home care, particularly in the area of geriatric and psychiatric. So they follow their part of the multidisciplinary team. They go for home visits to do home medication reviews and things like that. So you can see here clinical pharmacy services in Malaysia, similar to other places around the globe, expanding. I'm sure if I give the same talk maybe 5 years or 10 years from now, there'll be more services covered by clinical pharmacy. Right, so just a little bit of MTech, just like the MTM in Thailand. MTech in Malaysia was established since 2004. The primary objective is to improve patients' adherence to medications in ambulatory care settings, meaning in outpatient setting. So at the beginning, most of this session are to improve patient compliance or adherence to medication. But in recent years, more and more pharmacists also get heavily involved in clinical monitoring of the patient and maybe dosage adjustment of the drugs. For example, in Diabetic Clinic, adjustment of insulin dose, or to teach the patient how to self-adjust the dose. In Heart Failure Clinic, for example, Heart Failure MTech, the pharmacist also involved in advising on dose titration of all the medication. So these are some of the currently available MTech. So these MTechs also have established protocols published by the Pharmacy Division of Ministry of Health. So we have the early ones in 2004, for example, the MTech started with anticoagulant, then diabetes, and now the newer ones like heart failure, which started around 2018 or so. So when we establish services, obviously we need to know whether they are effective or not, because these are time-consuming and take up resources. So this is just example of the MTech, heart failure MTech in Sedang Hospital in Selangor. Just for your information, Sedang Hospital is a Ministry of Health hospital. It is a cardiac referral tertiary hospital, and it's very close to University of Cyberjaya. So we have really good relationship. We send a lot of students there for clerkship, from Bachelor of Pharmacy to postgraduate programs like Masters in Clinical Pharmacy and Doctor of Pharmacy. So the heart failure MTech there in Hospital Sedang started in 2018. This is a photo of the protocol published by the Ministry of Health for the heart failure MTech. So how do we know whether the MTech is effective or not? At University of Cyberjaya, we try to help our hospital counterpart as much as we can. See, for example, in this, the heart failure MTech started in 2018. So last year, 2019, we had a couple of our students to conduct, this is undergraduate students. So they conduct simple research to see the effectiveness of the heart failure MTech. So the first study, on the left is actually looking at the effects of MTech on knowledge, attitude, self-care practice of the heart failure patient. So comparing it with control group who are not attending the MTech clinic. And the second study on the right, is looking at the cost effectiveness of the MTech clinic. So both studies actually give good results. The first study actually shows significantly increased knowledge level among the heart failure patient who attended the heart failure MTech as compared to the control group, even though there was no significant differences in attitude and self-care practice. But this is because the baseline attitude and self-care practice were good to begin with. So that's why you don't see much of the difference. And the second study actually shows that even though when we establish MTech, you actually have more human resources and time, but in the long run, it actually cost effective. So this study here shows that the heart failure MTech is actually cost saving as compared to the patients in the control group. Because there is reduction in ED visits and length of hospital stay, if I'm not mistaken. Okay, so this is how we, from the university side, help our hospital counterpart. We work together so that the clinical pharmacy services can be expanded in a structured and evidence-based manner. These studies have not been published yet, so hopefully we'll find a bit of time to publish these two studies, hopefully by either end of this year or early next year. Okay, as I mentioned earlier, when you've been in the clinical practice for many years, you start to think of, okay, where do we go from here? Say, for example, in Thailand, they are quite established in terms of specialization. So in Malaysia, we do have specialization as well, but at the moment, there is no particular path. For example, our clinical pharmacists, most of them, or it's the trend now that they will, after a few years being in hospital, they will go on and take masters in clinical pharmacy, either from the public or private universities like us. But also, they will talk a lot of debates and talks about the recognition of the specialty itself. So in 2010, the pharmacy division, Malaysian Ministry of Health, actually come out with this credentialing activity. So this credentialing, the primary objective is to identify and provide recognition to pharmacists with competency in the specific areas of practice. So on these slides, these are the modules that has been recognized for credentialing. For example, critical care ICU, PEDS, clinical pharmacokinetics, TDM, and things like that. So there are modules for the pharmacists to go through before they can actually be credentialed. So at the moment, there are already 400 plus pharmacists that has been recognized through this credentialing. The list of pharmacists and their area of credentials are actually listed in the pharmacy division website, so you can have a look there. But they also need to maintain their name in the list, so they have to actually renew their credentials. Okay. On top of that, Ministry of Health under Pharmacy Division in 2018 has also introduced subject matter expert. So SME. This SME is actually more of to recognize the experts among the pharmacists. So this is something similar to specialists. You know, in medical line where they have specialists. So in pharmacy in Malaysia now we do have CME. Sorry, SME, not CME, SME. Okay. Currently, there are only 3 SMEs identified and appointed. One is pharmacotherapy in infectious diseases. The other is pharmacotherapy in anticoagulant. And our beloved Dean, Prof. Datin Dr. Rosnani, our Faculty of Pharmacy Dean, was actually involved as in the selection committee in appointing the SME for this anticoagulant pharmacotherapy in anticoagulant. The other SME was not in is not in clinical pharmacy, but is more on in regulatory clinical trials. Okay, so far in clinical pharmacy we have 2 SME, one in infectious disease and the other one is anticoagulant. So there are strict criteria to be appointed as SMEs. For example, the pharmacists need should possess a minimum of masters or PhD in the related area. So in pharmacotherapy for anticoagulant and infectious area, they need to have a master's in clinical pharmacy, obviously, since they are clinical pharmacists, and PhD in the related area. So both of our SME now are PhD holders as well. So they also need to be in service for a minimum of 14 years and in the subspecialty area for a minimum of 5 years. Say, for example, if you want to be a SME in infectious disease, you should be practicing in that area for a minimum of 5 years. So what are the roles of this SME? They provide consultation, meaning that they are the point of reference. Say for infectious disease, for Malaysia, the SME will be the point of reference for any issues relating to infectious disease. They should also be giving talks and presentations at national and international levels. They should also be mentoring and coaching young clinical pharmacists or young pharmacists in general. And most importantly, to be involved in research and publications in the area, in the subspecialty areas. So for example, for our students, our Doctor of Pharmacy students, we have 2 Doctor of Pharmacy students now doing research in infectious area. So the SME in the infectious area are now the co-supervisors for our students. Right, so that is a little bit on clinical pharmacy services and the progression in Malaysia. Now I will just touch very quickly on clinical preceptorship practices in University of Cyberjaya. Okay, in University of Cyberjaya, we have clinical pharmacy courses in 3 programs. One is undergraduate degree, Bachelor of Pharmacy. Then we have 2 postgraduate degree. One is Masters in Clinical Pharmacy and the other is Doctor of Pharmacy, PharmD. So you can see here from the triangle, this triangle is actually representing the number of students. You can see that Bachelor of Pharmacy, we have a lot of students. And then the number dropped from Masters to Doctor of Pharmacy. Currently, Doctor of Pharmacies, we have 6 students in various years. Hence, with this number of students, the level of preceptorships also changes. For Bachelor of Pharmacy, for clinical pharmacy courses in Bachelor of Pharmacy, students are sent to various hospitals. So for example, year 4 student, we have about 60 plus students. So we send to various hospitals around Cyberjaya, as far as Negeri Sembilan, Seremban Negeri Sembilan, for their clinical clerkship. So clinical preceptors for these students are the clinical pharmacists working at the training sites. So depending on the type of clerkship that they have to go, say for example, they have to go for internal medicine. So the preceptors are the pharmacists working in the internal medicine ward at that time. So what are the roles of the clinical pharmacists? They are actually to provide briefing at the beginning of the clerkship. They introduce students to the wards and ward personnel, and to facilitate for the students to be able to join the ward rounds. So usually we have, say for example, we have 10 students in a hospital. So the students will take turn to join the ward round. Usually maybe 2 or 3 students only at any one time to join the ward round. So with the big number of students, we know clinical pharmacists in the ward are very busy. They don't have much time to spend with the students. So we don't expect our preceptors to discuss cases with our students. That is done by us, the clinical pharmacy lecturers, the supervising clinical pharmacy lecturers. So for case discussion and assessment, for example, the assessment that we have is bedside viva and presentations. All are actually conducted by the lecturers. So our clinical preceptors at the hospital are not involved much with the case discussion and assessment. For Masters in Clinical Pharmacy, similarly, students are sent to various hospitals. For example, for 4 weeks for compulsory clerkships. Compulsory clerkships can be, there are 4 compulsory clerkships: internal medicine, infectious disease, ICU, critical care, as well as pediatrics. So they spend 4 weeks each in this clerkship and 2 weeks for elective clerkship, which they can choose. For example, oncology, nuclear pharmacy, TDM, TPN, psychiatry, geriatric, for example. So who are the clinical preceptors appointed? They are still the clinical pharmacists, but specialized in the area. Say, for example, if our students want to do geriatric as an elective clerkship, as much as possible, we send the students to the hospital where they have the geriatric ward. And the pharmacists that become their preceptors are the pharmacists working in those wards. And the roles of these clinical preceptors are, as before, provide briefing at the beginning of the clerkship, introduce students to the wards and ward personnel, facilitate for the students to join the ward rounds, and answer specific inquiries on the clerk cases, and maybe sometimes they conduct short case discussion, but we don't make it compulsory for the clinical preceptors to discuss cases with our students. Again, the case discussion and assessment, the assessment that we have is case presentations, case reports, and logbooks are conducted by the supervising clinical pharmacy lecturers. So the lecturers will do all this, not the hospital preceptors, because we don't want to load the hospital preceptors with too much work. You can see here the photos of UGM students who came to us. I think the bottom photo was 2017, maybe 2017 or 2018 for geriatric attachment. They went to hospital Kuala Lumpur for geriatric attachment. And this is last year group. They went to Hospital Tuanku Jaafar in Seremban with our lecturer here, Dr. Yaman, for the internal medicine attachment. Okay, I think they were with us for 2 weeks, if I'm not mistaken, because I was not involved in this attachment, so I can't really remember. I think minimum 2 weeks, but last year they were here for 1 month, if I'm not mistaken. Correct me, Prof. Zulis. Okay. For Doctor of Pharmacy, so students are sent to various hospitals according to specialization. In our pharmacy division, Ministry of Health actually have identified which hospitals for which specialization. So we have, for example, Hospital Sedang is the cardiac center, Hospital Sungai Buloh for the infectious disease, something like that. So the preceptors for our Doctor of Pharmacy students are the clinical pharmacists specializing in the area. So again, the role of the clinical preceptors to provide briefing, to introduce the students to the ward and ward personnel, and at intervals, discuss cases. So for Doctor of Pharmacy, our preceptors usually will discuss cases, and even because our Doctor of Pharmacy students, they are expected to do interventions to identify pharmaceutical care issues. Pharmaceutical care issues is similar to DRP, except that it's broader. So usually they would actually seek confirmation from the preceptors before they actually do the interventions with the medical doctors, for example. And tasks to be completed. Sometimes our Doctor of Pharmacy students, they need to do ADR reporting, they need to counsel patient, they need to do TDM. So all these tasks will be discussed with the clinical preceptors. And our clinical preceptors also assist us in providing exposures to our students on other related services. Say, for example, when our PharmD students go to Hospital Sungai Buloh for infectious disease clerkship, they may be there for 2 months. They will also join relevant other services, say, for example, the antimicrobial stewardship. Our students actually completed the AMS module while they were doing the infectious disease attachment, as well as MTech, say maybe the RBD MTech. For Doctor of Pharmacy, the preceptors also assess case presentation. For Doctor of Pharmacy, we have 2 presentations for each clerkship. One is at the hospital on site. So the preceptors will assess their case presentation together with the lecturers. And then they will also have another case presentation conducted at the campus, which will be assessed by the pharmacy lecturers. During the specialized clerkship, for Doctor of Pharmacy, they have this specialized clerkship at the end of their 3rd year, in their 5th semester. So they are supposed to conduct research for that chosen specialized area. So our clinical preceptors also act as co-supervisors for the research. So you see the different level of preceptorship by our hospital clinical pharmacists, preceptors. So for the lecturers, still we conduct case discussion and assessments for our PharmD students. So you can see here photos of our PharmD students. The one on the left is our second year PharmD students. They went to Chiang Mai University for their infectious disease, 2 weeks in Chiang Mai before they continue the infectious disease clerkship in Malaysia. The second photo is actually our third year PharmD students. They actually choose infectious disease, so their research was in infectious disease area. So in this photo, they just finished their proposal presentation. So the presentation was attended by the chief pharmacist, who is actually the CME for infectious disease, SME, not CME, SME for infectious disease, as well as attended by the infectious disease doctors. So the research is actually in collaboration between pharmacy, University of Cyberjaya, and the medical department. The last photo here, was taken just recently, this week. This is our second year PharmD students who just started their pediatric clerkship in Hospital Sedang. These are our students with Madam Diana, who is our lecturer. During the COVID-19 MCO, we had to stop our doctor of pharmacy attachment. We did not convert it to online clerkship because we feel that for doctor of pharmacy, they need to actually experience the hands-on training. So during the MCO, the student actually spend the time to prepare for their research proposal presentation. And only this week, they start to go back to hospitals. They are allowed to enter the hospitals again. So now they are starting the pediatric attachment. In 2 months' time, they'll go into ICU with me. So that is the clinical preceptorship for our program, for our degree and postgraduate programs. We also, University of Cyberjaya is also one of the 9 training premises approved to conduct PRPship. PRPship is to actually get a license to become registered pharmacist. So UOC or University of Cyberjaya is one of the premises that can conduct PRP training for R&D in academia. So students undertaking postgraduate program like with us, Masters in Clinical Pharmacy, Doctor of Pharmacy, MSc in Pharmaceutical Sciences and PhD in Pharmaceutical Sciences can also register to complete their PRPship at the same time, meaning that they get the postgraduate certificate as well as they get the license to practice as pharmacists at the end of it. So for this PRP training, the lecturers become the research supervisors, and also we are the immediate preceptors for the PRP training. So you can see here, this is a photo of the PRP logbook that they have to complete and submit at the end of the training. They need to submit to pharmacy board for them to be registered as practicing pharmacists. Right, so that's a little bit on preceptorship, the different level of preceptorship in University of Cyberjaya. Next, just a little bit on clinical clerkship during the COVID-19 movement control order. Just for your information, for our year 4 students, year 4 Bachelor of Pharmacy student, they are supposed to have clinical simulation week from 16 March, and clinical clerkship at designated hospitals was supposed to start on 23rd of March. But on the 16th of March 2020, our Malaysian Prime Minister announced that the movement control order would be enforced 2 days later. So it was a very confusing period for us. How did we respond? So what did we do? Our students were supposed to go to hospital for their clinical clerkship. Now we cannot do that. We have to be at home. We have to stay at home and cannot go out. So what do we do? So what we did, okay. So what we did is actually converting our clinical clerkship fully online. So our clinical pharmacy lecturers rush and work very hard to prepare online cases like this. So what we did was, we created clinical cases, and the clinical cases created has to be as close as possible to represent the real clinical cases and settings, because now the students cannot go to hospital for the hands-on experience. We have to create something similar. So the cases were created in Microsoft OneNote and uploaded to our learning management system, Moodle. We use Moodle in UOC. And we conduct ward rounds and case discussion on Microsoft Teams. So during this online clinical clerkship, our clinical lecturers actually role play as consultants, as medical officers, as nurses, as senior pharmacists. And the students they have to role play to be PRP, pharmacists, young pharmacists. So this is how the Microsoft team looks like. So we are all online, the lecturers and the students, right? We were broken into small groups. So like for example, this is me with my group. We were in Ward Anggerik, and these are how the clinical cases look like. You see, when we create the clinical cases on, why we use Microsoft OneNote is because in OneNote you can have the different tab. So you have like a different file for clinical progress, for the observation chart, for the medication chart, for the lab results and things like that. So you can see here, even though the cases are typed, but we try to make it as near or as similar to a real bedhead ticket. So we actually use different fonts. We have even, you see, we even have like a stamp, like a doctor stamp, you know, in the bedhead ticket to assimilate how the bedhead ticket in hospital is. So we try to make it as similar as possible. Even we upload the medication chart just how it is in the hospital. So hopefully this exercise will still give our students similar experience as how they would be in the hospitals, minus the sweat of going around the ward actually. Okay, so that's a little bit of experience sharing from me. Okay, thank you very much. That's all.
Thank you very much for the interesting.
Oops, sorry. Okay.
Mbak Vita unmute Mbak Vita. Yep.
Okay. Say again, thank you very much for Dr. Zairisa for the very interesting presentation. Now we came to Miss Perdani Adnin Mainsyah. Miss Perdani Adnin, actually she is finished the postgraduate, but when she go to the internship for the last years, she is still a student of the Master of Clinical Pharmacy. Before she joined with us, she have worked at the some site like Puskesmas in Puskesmas is the like primary care in Papua, and also in a Japanese clinic. Yeah. In this presentation, she will talk about the learning experience when she following the internship in Sai Berjaya University, and also this presentation will talk about the example of case study from Indonesian hospital, a case in pediatric from Indonesian hospital. Actually, from our student, we send our student in some tertiary hospital in Indonesia, and also we send in currently three abroad, three sites abroad. Two of that is the Bumrungrad Hospital and the Cyberjaya University, and we also send our student to universities in Malaysia to follow drug information and they following internship also in the Pusat Racun Negara in the Malaysia. Okay, for the Ms. Pardani, you have 30 minutes for the presentation.
Okay,
please.
Okay, I will try to share my PowerPoint.
Okay.
Everybody can see my PowerPoint.
Yes, okay.
Okay, how about the voice, Gita? Is it clear?
Yeah, it is very clear.
Okay, yeah, thank you very much for the opportunity, Dr. Vita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Thank you for joining on this webinar. Let me introduce myself. My name is Pardani Admin. Today, I will share my learning experience in Cyberjaya University, especially in geriatric internship. And this presentation split to two sections. The first section is I will share the learning experience in geriatric internship in Cyberjaya University, Malaysia. And the second section, I will share about the example of case study, especially I take this case from Cipto Mangunkusumo Hospital, Jakarta. So we start with the first section, the learning experience in geriatric internship. So in the geriatric internship in University of Cyberjaya, the duration of the geriatric internship is 4 weeks. In this first week, this is the induction week, where we have a lecture and also the presentation case. And in the second week, we have a geriatric pharmacotherapy involved the geriatric lecture and individual presentation of general pharmacotherapy case. In the third week, we have a geriatric internship involved the we went to geriatric internship on Hospital of Tengkuanku Jafar Saramban and also make the presentation of the geriatric case that we taken in those hospital. And in the last week, we have the OSCE. The experience in geriatric internship in Cyberjaya, it's really interesting because in this internship, I can have experience internship in the local hospital of Malaysia. Especially the most interesting is we can to develop how to read the medical record in hospital of Malaysia with different style from the Indonesia. And also we can look the clinical pharmacies in Malaysia, which is more confident to implement their clinical pharmacy ability. And also in this geriatric internship, we not only have the internship, but we also have the lecture like a student international. Let's start with first week. In the first week, overall in the first week, we have a lecture with other students in the classroom. The lecture actually conducted in English. Uh, Here the lecture that I got, especially the lecture mostly about how to interpret the laboratory, because this lecture is the step for preparation to have the internship for the next. And the geriatric internship, the lecture of the interpretation laboratory uh, was delivered by different lecturer, and also in this lecture we also have the vaccination workshop. This is one of the picture when I have a vaccination workshop in the University of Cyberjaya. And in the last of this first week, we have an assignment to have an individual mock presentation about the general pharmacotherapy, which deliver in second week. So after we have a preparation for the mock test presentation, we presented the general pharmacotherapy case in the second week. The mock presentation was delivered in small group, around 3 to 4 students in front of 2 lecturers. It was a great experience because each lecturer of University of Cyberjaya is very full concern for every student to have the presentation. And in this occasion, we received a lot of suggestions related to our presentation. And the most memorable thing of the presentation in Malaysia is no matter how many your slides in the presentation must be conducted in 10 minutes. So you can imagine when you have the patient with complicated case and the long duration of therapy, but you still presented the case only and on 10 minutes. So you must choose the most important finding of those patients. In the second week, the activity also the geriatric lecture. In the geriatric lecture, we learn about the principle of pharmacotherapy in geriatric population. And the second is we learn about the common geriatric assessment and geriatric syndromes. And the last we learn about the common drug-related problem in geriatric and recommend the optimal pharmacotherapy plan with appropriate monitoring parameter. After we have geriatric lecture, we went to third week, which is we have the internship in hospital of Tuanku Jafar Seremban. In this week, we went to the hospital for 2 days. In 2 days, we must select one patient in geriatric ward. And in this hospital, we also have a discussion with pharmacists on duty in hospital of Tuanku Jafar Seremban. After we selected the patient, we clerked the selected case from geriatric ward in hospital of Tuanku Jafar Seremban, and also we have a medication history taking with the patient's family. And the last, after we select the patient, we discuss the case with the pharmacist on the ward. Okay, after we perceive the patient condition from the geriatric ward, we make an assessment related the therapy and also the geriatric patient condition to have a presentation. For presentation of geriatric case from hospital of Tuanku Jafar Seremban, we always consider about the geriatric giant. The geriatric giant included the urinary incontinence, immobility, instability, intellectual impairment, and also iatrogenic. The assessment also consider the functional assessment in the elderly, such as physical and psychiatry function. And the last, we consider about the potentially inappropriate medication. Sometimes we can use the BIRS criteria or stop start or high risk medicine list and also anticholinergic drug scale. Okay, this is the activity in the fourth week. The student in geriatric internship have OSCE. You can imagine when OSCE in Indonesia, it's also so difficult. Absolutely no, not different with the OSCE in English. So this is and also a great experience for us because this OSCE have very different atmosphere with the Indonesia OSCE, right? We have this OSCE in one time. So there are two cases that should be conducted in here. First cases is community pharmacy case and second cases is hospital pharmacy case. In community case, we can see on the on the right picture, there are someone who pretend to be a patient and we must simulate it to give counseling related to patient condition. And left picture is this is hospital pharmacy case OSCE, which is someone who pretend to be a physician and the surgeon simulated to recommend the optimal pharmaceutical care to the physician using evidence-based medicine in here. So that's all of the presentation about the experience in University of Sriwijaya, especially in geriatric internship. And we go to the second section. Actually, in the if the learn experience, I talk about the geriatric internship in University of Sriwijaya. But in the example case, I will share about the case in the Indonesia hospital. Especially, I take this. I know absolutely this is a different thing, but I hope all of you will still gain more knowledge by joining in this webinar. I get this passion on my pediatric internship in Cipto Mangunkusumo Hospital, Jakarta. I got patient pediatric with retinoblastoma stadium 4 pro chemotherapy. In pediatric, retinoblastoma is the most common type of eye cancer that was often diagnosed before 5 years old. Sometimes the symptoms of the patient are the unusual child's eye, such as white pupil or redness of the white part of the eye or bleeding in front of part of the eye. So how we make an assessment about the case in Indonesia hospital? Let's start with patient identity. So when we make an assessment of a diagnosis, we must verify the patient's identity first. In patient identity first, it's very important to recognize which patient as our study case. Especially in pro-chemotherapy patient, the body surface area is important to calculate the dose. And especially in pro-chemotherapy patient, we also know which cycle patient chemotherapy is. And also on the retinoblastoma cases, we must observe about if the patient has undergone an enucleation or removal eyeball. And last, we never forget to assess the allergy of medicine patient. That we need to be aware about the allergy of medicine patient, so we could suggest the best recommendation therapy for the patient. Okay, next is course of disease. It is important to perceive the course of disease of the patient, especially in pediatric oncology disease. We must know the course of the disease of the patient began. The earlier of cancer was found out, the more likely the successful therapy to be achieved. And also, the chemotherapy also has several steps And so by we perceive the cause of disease, we can knowing in which patient step right now. Okay, this patient diagnosed retinoblastoma in January 2018, and right now she is in fourth chemotherapy. This is the protocol chemotherapy in retinoblastoma high dose. Here, the protocol only available on medical and patient record. It is very important to know the chemotherapy protocol patient is retinoblastoma protocol has 8 cycle, and every fourth cycle the patient will have the evaluation. The protocol cover uh, the name of agent of chemotherapy, the doses, and also maximum dose, and also the route of the therapy. Uh, Another that in protocol, the in protocol chemotherapy protocol covers about the chemistry blood test or an imaging, and also complete blood count of the patient. So the record patient clinical outcome and laboratory data is very important to monitor patient condition based on maybe our observation or either based on the medical record of the patient. In this uh, record record of patient clinical outcome, we can monitor is it any change of patient compliance or any possibility of after effect of the agent of chemotherapy, or is the cold therapy patient were assessed. So the worst condition of the patient could be minimalized. The patient undergo chemotherapy must meet the requirement to have the chemotherapy, such as the absolute neutrophil count and hemoglobin. So we in the laboratory data, we must observe about the hemoglobin and the leukocyte and also the neutrophil. And other laboratory data was also observed to monitor the effect of each chemotherapy agent, such as here only liver function test and also renal function test, and also the imaging of the CT of brain. Due to agent ectotomy is a cytotoxic drug and the patient is in the childhood dose, each agent used by the patient must be assessed by route and also the dose. Especially in the dose, we must assess the literature dose, estimated dose, a maximum dose, and also the administration dose. So based on this data, we can give the recommend the safest dose. And also, when we make an assessment in the pharmacotherapy, we must assess about the pharmacology profile of each agent of chemotherapy, such as the mechanism of action and pharmacokinetic, the solvent, storage and stability, and also this administration. Okay, each of agent chemotherapy does not dilute in all solvent, so we must find out the best solvent for the each agent, and also the handling cytotoxic chemotherapy agent in pediatric often leave often leaves the drug residue due to the small dose required. So it is important that we analyze and we look for the storage and stability of the agent of chemotherapy so we can allow the drug residue to reuse later. Since the agent of chemotherapy are would have a vesicant or irritant, it is important to analyze what the best administration of each agent. Chemotherapy needs handling cytotoxic, so it is important to us to make the schedule of administration of chemotherapy, such as in here, patient receive vincristine, etoposide, carboplatin, and second etoposide. So here we make this sequence of how the how the agent of chemotherapy administered to the patient. And also we must analyze about the infusion of the rate of the agent, and also we must assess the premedication of the agent. So if we make the schedule of administration chemotherapy, it will safer to patient condition. There are two medical problems on this patient. First is retinoblastoma stadium 4. In medical problem, we analyze the case through SOAP method. And SOAP method consists of subjective, objective, assessment, and plan. In subjective and objective, subjective content is complaint or main complaint of the patient related to the medical problem, also our observation of the patient and history of the patient. While in the objective, we have a diagnostic examination such as complete blood count test or chemistry blood test. And the assessment, in the assessment, we make an explanation of our finding related to drug-related problem for each patient of medical problem. After we make the assessment, we make the plan. The plan is a next action based our finding in assessment. Let's discuss the first medical problem. So, patient with retinoblastoma admit to hospital with history third cycle of retinoblastoma chemotherapy high dose at September 2019. And the ANC and also the hemoglobin met the criteria for the fourth cycle chemotherapy. The chemotherapy given in 2 days, which is first day, patient received vincristine first due to the physician of the vincristine to minimize the extravasation. And the second patient will receive etoposide for first dose due to the less irritant and lower emetic than other agent. And the last patient received the carboplatin because the carboplatin is the high emetic of agent of chemotherapy. And the second day, patient received the etoposide, which is the second dose. Our assessment based on the agent of chemotherapy, the regimen of protocol that given have met the principle of chemotherapy because the agent of chemotherapy have different mechanism on the cell cycle. But the important finding of this medical problem is the administration of carboplatin without the hydrogen of intravenous. So based on this assessment, we make a plan still to have an evaluation of chemotherapy through the lumbar puncture, bone marrow puncture, and imaging, and also still a tight monitoring about the adverse effect of the medicine, of the agent of chemotherapy. And the last, based on the important finding, we must give the education about the patient that must be keep the fluid intake. Okay, let's go to the second medical problem. So the second medical problem is patient have nausea and vomit with the subjective patient have nausea. Our assessment found out that carboplatin is the high emetic agent in the pediatric, but the time administration of ondansetron as a premedication was not given before the administration of carboplatin. And onset of action of ondansetron is 30 minutes before the 30 minutes. So the ideal time to give the administration is 30 minutes before the carboplatin. And also, if frequency of nausea and vomit increase of the patient because any possibility of delay nausea and vomit, the dose of ondansetron might be increased up to 16 milligrams per day. Based on our assessment, we make a next action that we recommend to give the ideal time of administration ondansetron 30 minutes before carbohydrate. And we must also monitoring the frequency of nausea vomit and also delay nausea vomit and post nutritional intake. And nausea and this is the monitoring and education of this case. In monitoring, we must analyze the emetic, the vesican, and also the adverse effect of each agent of chemotherapy. By finding this out, we can determine which the most important of those that must be monitored on this patient. So based on emetic and vesican adverse effect, we must monitor about the extravasation of infus located due to the ventilation administration and also monitor when working, the defecation and also the renal function. While in the autoposet, we only monitor the complete blood count and also liver function. In the carboplatin, because it is a high emetic potential in pediatric, we also have a tight monitor the nausea and the vomit of the patient. And also, carboplatin have a ototoxic adverse effect, so we should monitor the evaluation of hearing function of the patient. And also, as the clinical pharmacist, we are obligated to give an education to the patient related to the therapy. So the education that will given of the patient is the patient must occupy the fluid intake around 8 glass each day. And also, if patient go to home, she and her family must be aware on febrile neutropenia but recognize the symptom of the infection. Okay, so we are on the last presentation of the case study. In here, we must make a conclusion and suggestion based our assessment on the case. Maybe in the conclusion, we might find out about is it the therapy suitable with the patient condition and the literature, or is it the therapy harmless to the patient, or is it any mistake about the therapy? And what about our important finding of the assessment of this patient? And we must make a suggestion based our conclusion. So in this patient with retinoblastoma, the conclusion is the patient had met the chemotherapy requirement, which HB more than 10 milligram and also the ANC more than 1000. And also based on our evidence-based medicine, the retinoblastoma high-dose protocol that given to the patient have met the principle of chemotherapy, which is each of agent of chemotherapy has different mechanism on the cell cycle. And also, our important finding, the administration of carboplatin without the hydration of intravenous, and also the ondansetron as pre-medication was not given 30 minutes before high emetic agent of chemotherapy. So the suggestion of our conclusion is please give the education to keep the fluid intake and take monitor about the frequency of nausea vomit. And second, please give the pre-medication of ondansetron 30 minutes before the highest emetic agent of chemotherapy. Okay, that's all the presentation. Thank you very much. I give the back to the moderator, Pupita.
Yes, thank you, Mbak admin. Yeah.
Okay.
Now we come to the question and answer. We have some question here. First, there is one question for Dr. Sairisa. The question is from Ibu Amitasari that asks about what is the most common drug-related problem in geriatric patient? Doctor, maybe you have some experience from your side.
Okay, I think that question is meant for Danny, right? Danny, right? Because I don't go into geriatric much.
I see.
My area is
Yeah.
more of cardio and ICU, but I think in general, a lot of the issues were like things like falls and the use of anticholinergics, right? But maybe Bardani can actually answer more because she has seen quite a number of geriatric cases, right?
Okay, but Pardani, maybe you can add some information about the some drug-related problem that you have seen during the internship.
Okay. Maybe I can share about the presentation letter, the presentation. So in the geriatric ward, it's always fine about the drug-related problem because actually the geriatric patient always receive many medicine to cure the disease. So in the geriatric ward, we always make an assessment regarding the first is we always consider if is the chemotherapy is the therapy for the patient safe for the eye mobility of the patient, or is it the patient cured by the family, because if the patient guide with the healthcare health her family, is it possible to give the best recommendation and there is someone to make like to guide the medication. Maybe that's the answer, Bhuvita.
Yes. Okay. The next is for Dr. Sairisa again. This is no name here, but she asks how to start for clinical pharmacy side, I mean in the hospital, if this activity is new, very new in that hospital. I mean that in the hospital there is no activity of clinical pharmacy. So could you, Dr. Sairisa, told us how to try to develop this activity?
Thank you for the questions. I actually like this question because the problem is real. I remember back in the early 2000 when we want to start our clinical pharmacy services properly in our hospital before. Yes, we do have issues of maybe older doctors who are not very familiar and they ask, what are pharmacists doing in the ward, things like that. I always tell my students, if you want to start clinical pharmacy services, you must tackle the hearts, right? The hearts of the medical professions and the heart of the patients. So when we first started, we started with medical ward, where you have a big number of patients. So there we started with patient education. So when the patients actually know you, right, the words can go around very quickly. So they will ask, oh, the other day the pharmacist explained to me about how to use this insulin. I have more questions. Can you call the pharmacist and to see me again? You know, something like that. So you get good feedback from the patients, and the other healthcare providers will hear about it. Surely when they go for follow-up and see the doctors, they will see, oh, the other day the pharmacist explained this to me. So in other words, the doctors will know the benefit of having pharmacists in the ward. Another one is, I would strongly suggest that you start with therapeutic drug monitoring. Because we pharmacists, we are the best person, we are the right person, and we know clinical pharmacokinetics the best. When we first started, when I went into coronary care unit, CCU, I was the first pharmacist to enter CCU, because CCU previously was a very close-knit ward. You know, only even at the time, we don't even have house officers there, only medical officers and above. You know, the nurses there are all specialized nurse, the consultants. So when I went to CCU, the first thing that I offered was TDM. So when they see that you help them a lot with, say, for example, in CCU, we have vancomycin use, we have gentamicin use, amikacin use, particularly for infective endocarditis, cardio-related, right? So when they see your contribution, that you can help them a lot in managing the patients, especially the antibiotic, because doctors, they don't really know much about clinical pharmacokinetics, right? So when we actually recommend dosing adjustment, and they see the benefit of it, they see that the patient actually get better, the clinical parameters go back to normal, so they know your usefulness, right? So more and more after that, they will actually come and find you, ask you to be in the ward. So over the time, I think less than 3 months, we had the cardiologist who actually say, hey, why don't you join us for the rounds? And then it get expanded from there. So I think in summary, maybe start with TDM if it's a ward setting, and then maybe TPN. Those are areas that maybe doctors are not very familiar with. And of course, you would want to be popular among patients. So patient counseling is very important. After that, I think it will be easy. These days, it's the other way around now. It's not us who actually go to the ward to offer our services. It's the doctors who are actually looking for pharmacists. I remember when we first introduced clinical pharmacists in pediatric, after just 2 months, they actually asked for more pharmacists. Instead of one, they actually asked for 2 or 3 pharmacists, which we couldn't actually supply anyway, because we don't have enough pharmacists at that time. So I think it's not that hard, but you need to have the confidence. You need to be prepared. You must have updated knowledge. Updated knowledge is very important. Especially new trials, you need to know results of new trials so that you can give really good advice to the doctors and to the patients. Okay.
Yeah, thank you, Doctor. The next question is for Ms. Perdani. This is from Pak Victor, is our senior pharmacist. He asks, how intense is the communication among pharmacists and physicians with regard to chemotherapy preparation, including pre-treatment and also parenteral nutrition in ICU patient?
Okay. Actually, maybe I better to answer about how the communication among the pharmacist and physician regard to chemotherapy preparation. So in the pediatric internship, I only have the case about the oncology, but I don't have about the preparation. So we are only to discuss about the case with the oncology hematology pediatrician. But actually, in Cipto Mangunkusumo Hospital, the preparation of chemotherapy is in charge by the pharmacy. So all of the preparation, starting to which solvent that used in the preparation of agent chemotherapy is in charge by the pharmacy department. And also, how about the communication? Actually, in the pediatric oncology case, the pediatrician is very welcome with the pharmacy, and she told to me that we are as a pediatrician always asking the recommendation which the best solvent, or if the patient have any interact any adverse effect or something, they sometimes talk to the pharmacist in the clinical pharmacist. I think that's maybe it can answer the question, Mugita.
Yeah, thank you very much, Mbak Admin.
Okay.
There is still some question again for the Sairiza from the Ibu Amelia. She asks about she have two questions. The first is it's eligible for foreigner to study in any university in Malaysia in clinical pharmacy field. Is there any minimum requirement, or for instance, should hold any certificate or attend some test, hold English requirement, or etc. And the second question is this eligible for foreigner to work there in hospital or clinical environment?
Right, thank you for the questions. Yes, the answer is yes. We do accept international students. Perdana actually have experience working together with international students during the Masters in Clinical Pharmacy clerkship. So yes, we do accept international students. In terms of requirement, yes, we do need some English qualification. For example, we do require IELTS or anything that is equivalent. I think for full requirement, you can go to our university website, University of Cyberjaya, and the requirement for either Bachelor of Pharmacy or Masters in Clinical Pharmacy or Doctor of Pharmacy are all listed there, so you can have a look. In terms of foreigners to work in Malaysia hospitals, currently not so much. It used to be, we used to accept previously, but now not so much, because we also have quite a big number of our graduates, pharmacy graduates, and you need to be, you need to hold Malaysian license, license as a registered pharmacist to be practicing in Malaysia. So for now, no, but if you join our programs, you get to go to the hospitals to do the clinical work, like for the Masters in Clinical Pharmacy and Doctor of Pharmacy. So Doctor of Pharmacy is a postgraduate program, compared to in Thailand is a undergraduate program, right, Miss Amorite? But for Doctor of Pharmacy, because the clerkship is longer, so they get to experience a lot more of clinical scenarios in the hospital setting. Okay.
Okay. This is one question. One question that I also asked. Also, this is very nice question. This is from Dr. Zaki Holisoh, my colleague. She would like to know more about the case study simulation using that you previous tell to us. So this is like the amazing idea. During this COVID, actually we stopped all the internship or attachment. So we still think how to develop what that kind to replace, and also to replace, but still make could improve the capability of the study. And this
Yes.
is
Yeah.
how to simulate the case? Is there like any video, or what should the student doing there? Is there any discussion? Maybe you could tell to us more about this.
Yes, this OneNote idea to us, it was amazing. One of our clinical pharmacy lecturer had the idea. At first, one good thing is 2 years ago, I think 2 years ago, we actually started clinical pharmacy simulation. We have our simulation ward. So before our student goes to the hospital, we have 1 week of clinical simulation, meaning that in our clinical or ward simulation lab, we actually have our mannequin in beds, but we created, the lecturers created the files, just like normal medical files in hospitals. So we created simulated cases. So we have the BHT, we have the medical chart, we have the labs, for example. And during that 1 week of simulation, the student goes to the lab and acted as if they are in the ward. So the lecturers become consultant, pharmacists, nurses. So during ward rounds, we acted as consultant and asked questions, just like how medical doctors would ask questions to pharmacists, just to get the students to be prepared before they go to real hospitals. But for that simulation, we actually created manual files, the actual patient file. So when MCO occur, when COVID-19 occur, we thought, how can we convert this to online? At first, we actually use Words, just Microsoft Words. Then the problem with Words is you will have separate files for different things, right? You have different files for the medical record, different files for the medication chart, different files for the lab. So one of our, I can't remember who actually came up with it, suggested, why don't we use OneNote? So all of us, just 2 days before the MCO, all of us really cram ourselves together and work on it. So we trial and error with OneNote. We converted the words to notes. Then we try it on Microsoft Teams, and it worked. One good thing about OneNote is during the work round, the students also can write in the file. So because it's being shared, the file is shared, so the students can also write. Say, for example, they are like pharmacists. So they said, oh, seen by pharmacists, we would like to suggest reduction of dose due to creatinine clearance. So all these things can be written on the OneNote as a recommendation by students or by the pharmacists, because they acted as pharmacists. Then we, the lecturers who are role-playing as doctors or nurses, can actually read and comment as well. So I don't have a video on how we did it, because we actually did it in a rush. It's just 2 days, 3 days before the MCO that we have to come up with this. Maybe in the future, we'll prepare something like a manual so that we can share with other people. So what I showed just now was just a screenshot of Teams when we had the ward rounds in Teams, in Microsoft Teams. Maybe we can share more once we have more later, if we have to repeat it again. In terms of the examination assessment, let me think. During the ward round, the assessment is more of formative. We just give feedback. So when the students actually make recommendation, at the end of it, we just say that, okay, whether your recommendation or intervention is correct or wrong, whether you say it correctly and things like that. So not so much of the teams was not assessed. There's no summative assessment, but later on, the student actually prepare their case presentation from the cases that they clerk during in OneNote, and then that case presentation is actually assessed. So during the MCO, the presentation, instead of we do it face-to-face like usual, the student actually prepare their presentation with audio, then they uploaded it to our Moodle, and the lecturers will download and listen to it, and then we give the marks. So it's not face-to-face, but how they present is the same. They will have the slides and they will have the audio as well. Okay, I hope that answers your questions.
Yeah, thank you very much. But I think the time is up now. We have 3 hours with this amazing presentation, and hopefully this will give the many benefit for our pharmacists in Indonesia and also Malaysia and Thailand. Thank you very much. And there is actually still many question here, but we will send to the presenter, and maybe will be give back by the email from the someone who give us the question. I will give back this time to Mbak Saras, maybe to close the session.
Yes, thank you, Dr. Vita. Eventually, this last session concludes this webinar. We are still on schedule, so thank you for following through with us. I'd like to once again extend our special thanks to the speakers and the moderators, also for the participants. Thank you for joining us. As a kind reminder, please do not forget to complete the attendance confirmation form. It is available until 12:30 only. And for those of you who would like to access the recording of this webinar, it is available on the YouTube channel of Kanal Pengetahuan Farmasi UGM. If you are interested in accessing the contents, please subscribe and click the notification button to get updated with the upcoming webinar. I wish everyone here have a very nice rest of the day or a very nice weekend perhaps. Stay safe, happy, and healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much for all participants and also for our speakers. Nice to meet you all, and yeah, very amazing.
Thank you for the invite.
Yeah.
Have a good weekend.
Yeah. Hopefully we still keep contact for the next the future. Yeah.
Thank you, Amolat.
Thank you, Vita, and all for Professor Suri also.
Hopefully can see you again in the
soon.
Hope the COVID pandemic's getting decrease. Yeah, but still in Indonesia we still have increase, the case. Yeah. Okay, thank you very much. Yeah.
Bye bye.
Bye, thank you.
Yeah.
Bye.
Nggak pakai foto-foto dulu ya. Udah ya tadi ya, udah foto ya.
Awal sudah foto.
Udah foto ya. Iya. Bisa, alhamdulillah udah selesai.
Alhamdulillah.
Emang ada beberapa pertanyaan. Tadi aku mau nanya tapi nggak jadi. Soalnya gue mau ngerti. Itu tuh master, itu tuh selevel master, Mbak. Dokter of Farmasinya, fundingnya itu selevel master. Itu sama kayak modelnya Singapura.
Oh, mulai dari tahun pertama ya,
Enggak, Singapura itu master, Mbak. Kalau yang di Thailand kan PharmD-nya kan S1, bachelor. Kalau di Thailand, PharmD itu adalah bachelor, jadi 4 tahun.
Oh ya.
Tapi kalau PharmD-nya saya Berjaya, itu selevel master.
Oh, jadi 6.
6, ya. Dengan more praktek ya, dengan ini. Oke, thank you semua partisipan.
Terima kasih kami ucapkan kepada
Tidak ada post-test ya, tidak ada post-test. Silakan bisa, jangan lupa yang belum belum daftar hadir, silakan mengisi daftar hadir.
Sertifikat nanti insya Allah akan
dikirim via email. Ya. Terima kasih semuanya.
Terima kasih.
Daftar hadirnya tadi sudah ada di linknya, bisa dilihat lagi ya.
Untuk materi nanti akan bisa dilihat kembali di channel YouTube-nya. Jadi di channel YouTube itu biasanya sudah ada materi.
Record ada ya, ada
materi terus
rekaman.
Ya. Jadi kapanpun bisa diputar ulang begitu, akan lebih senang.
Ya, salam semuanya buat para partisipan yang kepengen join dengan MFK nanti tahun depan. Sekarang udah tutup soalnya.
Jika mungkin ada yang pengen ke Thailand, sangat menarik Thailand dan Malaysia ya.
Thailand tuh menariknya kelapa muda.
Oh iya, seger sekali ya. Prof dulu ya. Selalu